Hi there, I'm Robyn Puglia. I'm a clinical nutritional therapist and functional medicine practitioner, and I am the founder and principal of the Autoimmune Academy, which is a postgraduate program for doctors and nutritional therapists that focuses on working with people with autoimmune disease in clinical practice. And as we come to the end of 2025, I actually just really wanted to take a moment to reflect on 2025 because I feel like a lot shifted this year in a way that I find significant, almost not seismic, but there's been a real change in the ground underneath our feet. There has been a lot that has come out in the science and in the medical literature, but also in the realm of clinical practice and in the way that we apply the science and the literature to working with people in real life. And I also wanted to take a moment to reflect on what we learned inside the Autoimmune Academy as well. So let me start with what's new in science. And I wanted to start with talking about Epstein-Barr virus. So one of the biggest shifts that I've seen in the medical literature in the last 5 years actually looks at how Epstein-Barr virus is being discussed in the context of autoimmune disease. So EBV is no longer viewed as a background infection or as an incidental finding. It is actually increasingly recognized as being a critical environmental factor in the development of several autoimmune diseases. Specifically, we've seen some very important research come out around Epstein-Barr virus and multiple sclerosis and Epstein-Barr virus and lupus just this year in 2025, where they have found that EBV is necessary for the development of those autoimmune diseases. But what does that mean? What does that mean for our clinical practice? So let's start with the fact that globally, 90% of the population is infected with Epstein-Barr virus. This is not a rare virus. We essentially all have it. 50% of people are infected by the age of 5, and the other 50% are infected in teenagehood and adulthood. Epstein-Barr virus uh, creates a latent infection. It's part of the herpes virus family. And what that means is that once you have it, you are infected, and now it lives within your body as part of your immune system. And it has two phases of its life cycle. It has latent and lytic, and it can switch between those two. So lytic is active infection, and latent is when it is kind of shut down inside the cell. So it lives, it establishes latency, lifelong latency in humans inside our B cells and our epithelial cells. So the B cells are the cells of the immune system that are responsible for antibody production and antigen presentation. They are professional antigen presenting cells. So we now know that EBV has very strong associations with multiple sclerosis, lupus, rheumatoid arthritis, Sjogren's, autoimmune thyroid disease, and in fact, a host of other autoimmune diseases specifically. But they've started really looking at the epidemiology and the mechanistic understanding of what goes on at a cellular level in the immune system with EBV in the context of autoimmune disease. So there are two really critical things to understand about what is being said and understood now about EBV in the immune system. And I think that there are two important nuances that are being missed in this conversation. So, first of all, the medical literature is very, very clear that EBV appears to be necessary for autoimmune disease. Now, I don't believe that this is for all autoimmune disease. Specifically, this has been stated in the literature for lupus and multiple sclerosis. But it is necessary, but it is not sufficient. Okay. So EBV is necessary for the development of those autoimmune diseases, but it is not sufficient by itself for the development of those autoimmune diseases. It is part of the story, but it is not the story. It is part of the immunological lasagna. But with EBV alone as the only layer, remember, the reason that I call it the immunological lasagna is because a single sheet of pasta is not a lasagna. You need to have multiple layers, and by that I mean multiple immune events, in a specific order for the development of autoimmune disease. So a single layer of pasta, just EBV as a variable, is necessary for the development of autoimmune disease. It must be one of the layers in the lasagna, but it is not sufficient. By itself, it is not a lasagna. So I'm concerned because I'm seeing on social media at the moment that the takeaway message is if EBV can be cured, if EBV can be controlled, right, then the autoimmunity will be eradicated or cured in that person that has the autoimmune disease. But I understand that when you have multiple sclerosis or lupus or a life-changing autoimmune disease, that it is very, um, uh, it is very um, tantalizing. I'm stretching for a word here, but that you want to hear that there is a single magic bullet, that if only this thing can be taken care of, that you can be cured. But that isn't the story. And I'm worried that that is how it is going to be told. Autoimmune disease and EBV in the context of autoimmune disease is not a single hit model, right? It's layered. We must have genetics. We must have immune tolerance. We must have metabolic capacity. We must be thinking about stress and stress chemistry in the body, other infections, environmental exposures. There needs to be another variable that allows EBV to lead to autoimmune disease. So EBV is part of the immunological lasagna, but it is not the lasagna, and it's not even the top layer of the lasagna. And then the second nuance about EBV that I wanted to talk about is that a lot of this research is future facing, right? That it is medical literature being what it is. They are moving towards and thinking about a vaccine. So there is, so far as I know, EBV vaccine in development at the moment. I don't know how you feel about that, but I think that the idea of being able to prevent such an important variable is exciting, but it doesn't help the people who are already living with autoimmune disease, right? We are still years or even decades away from a medical intervention that might prevent that causal variable. So for the people who already have autoimmune disease, the question is not how do we prevent EBV? It is how do we understand EBV reactivation? How do we understand EBV in the context of the immune system? How do we understand the variables that lead to susceptibility of EBV in the immune system? And how do we support the immune system and support immune health and immune resilience now for this person who has, for you, or for this person, the person that we're working with who has already got a diagnosis of an autoimmune disease and also has an issue with EBV reactivation. So what does this mean for us clinically as clinicians? It means that we're not going to start studying, we're not going to start suddenly focusing all of our attention just on EBV, right? We need to be more sophisticated in how we assess EBV involvement, how we understand and work with EBV reactivation versus past exposure, like understanding for whom EBV has been the hammer that broke the window, but that may be years or even decades in the past, whereas for those for whom EBV is a problem now, we need to understand that in the context of COVID and mold and chronic stress and trauma and many things, right? So we have to understand in a sophisticated way where EBV fits in. We need to really understand the immune system and how to assess the immune system, how to look for biomarkers that help us understand immune exhaustion. We need to understand the metabolic context of the immune system because that's incredibly important for defense against infection. So it isn't about chasing viral eradication or viral suppression. It's about restoring the conditions under which the immune system can do its job. And I think that is the nuance that is being missed. Those two things, that it is necessary but not sufficient. And that what we're really talking about is immunometabolism and immune competence. And that our job is actually not to chase after eradication of the virus. It is to restore immune competence in the person that we're working with. Then the next thing is I wanted to talk about a quick celiac update. So we are seeing some really important and exciting shifts in around celiac disease testing. There was 2 papers published this year that talked about 2 new celiac diagnostic tests. These are newer approaches. They include whole blood assays and improved immune activation markers. So they're helping to detect immune responses that don't always show up on traditional screening. So the idea is that less people will be testing falsely negative. And that matters because celiac disease is still severely underdiagnosed, guys. Celiac disease rates are rising. They've gone from 0.8% of the population up to closer to 2% of the population. And while diagnosis rates have improved, they've improved from 10% to 15%, which means that 85% of people with celiac disease remain undiagnosed, which is making me feel crazy. So a big mission of mine for 2026 is going to be talking a lot about the need for good celiac disease screening and seeing if we can't improve diagnosis rates. So the new testing helps because it is sort of a move towards a broader detecting of immune dysfunction earlier rather than waiting for end stage damage, and also means that it is more broadly available because it doesn't require a biopsy for diagnosis. So that is very, very exciting for me. Now, I also wanted to, in my reflections on 2025, I wanted to talk. I went to 5 conferences this year, and I wanted to pick my kind of top takeaway. I think I really had 2, but at Jeffrey Bland's PLMI Thought Leaders Consortium, Dr. Vojdani said, made the statement, everything is metabolic and mitochondrial until proven otherwise. So this really puts a biological framework underneath what I see in my clinical practice and what I talk about a lot in the Autoimmune Academy. So, when we're thinking about immune system dysfunction and metabolic dysfunction, a lot of the symptoms and the presentations that we're talking about include fatigue and immune exhaustion and poor environmental tolerance. And this is fundamentally immunometabolic and mitochondrial, right? This is one interconnected system. And we do have a tendency to think about it as 3 separate systems: the immune system, right? Metabolic dysfunction, diabetes, cardiovascular disease, mitochondrial dysfunction, fatigue, neurological dysfunction, right? But the metabolic state of the mitochondria can directly dictate the immune system and immune function. Those 3 systems are so interconnected that they are actually a single system, right? The immune system doesn't just respond to threat. It also responds to available energy, to energy substrates, and to mitochondrial capacity. So when you have immune system dysfunction, you need to be considering metabolic dysfunction and mitochondrial function. Metabolic dysfunction meaning how we take food and turn it into energy substrate. Mitochondrial function being the ability to turn that substrate into energy. Those things are directly interconnected to the immune system. So in chronic illness, immune dysfunction might be an energy allocation problem, right? When this is an issue, adding more immune stimulation or targeting the immune system is not helpful and won't get you to your end goal, right? Supporting metabolic capacity is what is needed for those people. So that, I think, it is something that we all understand, right? We know that blood glucose highs and lows, like dysglycemia, elevations of insulin are pro-inflammatory, and that hypoglycemia drastically affects the immune system and also neurological function, just for example. But thinking about it in terms of, well, this affects that as opposed to this is an interconnected system is a different framework. And it also means that when we are assessing autoimmune disease or immune system dysfunction or complex cases like fibromyalgia and, ME, long COVID, that the initial thinking expands and that our assessment requires a specific framework. And I've just enjoyed having that kind of spelled out in black and white. That was really my big takeaway. So when you zoom out, what is kind of striking is that the EBV research and immunometabolism and the newer celiac immune system tests are all pointing in the same direction. That autoimmune disease is not a single trigger problem, right? It's coming back to that immunological lasagna. It is a systems problem. So the future then is not about chasing the loudest signal. We're not looking for the magic bullet. It's about understanding context and capacity and time. Okay, so then I wanted to reflect a little bit on some of the things that we talked about and things that we learned in the Autoimmune Academy and in the Inner Circle, which is my group that I host of graduates from the Autoimmune Academy. So one of the strongest themes that actually came out of this year was a shift away from doing more things, more, having the most complex, most sophisticated but packed full interventions, and moving away from more into actually doing less per intervention, but making sure that we got the sequence of interventions in the right order. So in the Autoimmune Academy this year, the cases that we workshopped together and worked through together were really complex, right? We are working in clinic with trauma, with infections, with postpartum collapse, with pediatric presentations of things, including autoimmune disease and immune system dysfunction, with heavy metals and mold and gut dysfunction and respiratory tract dysfunction and allergies. And often a lot of these things are layered together. So again and again and again, when we were workshopping complex cases, when we were workshopping through cases, the best outcomes actually didn't come from the perfect protocols and from doing more, but actually from doing less per intervention, from simplifying, but importantly, getting the interventions in the correct order. So this really allows us to work with the body instead of trying to push the immune system to do what we want it to do. The most therapeutic thing that we can do is stabilize physiology, support the nervous system, let the body feel safe, and then put the dominoes in the correct order and let them flow into each other. So we create a stable foundation, and then we build our interventions in a strategic order so that each becomes successful because it is built over the top of the one that comes for it. Um, and and be- when we are working in this way, it allows us to course correct as we go along. And the reason that this is so effective is because it isn't overwhelming, because we are creating safety and stability, which the body needs, and which the immune system needs in order to be able to accept effective intervention strategy, but also because protocol memorization doesn't really work. And we mature clinically when we move away from protocols and start really being able to apply strategic thinking. So something else that we talked about a lot over the past 12 months that isn't really talked about enough is actually the impact that this work has on the practitioner, right? So this year we had some very honest, very vulnerable conversations about imposter syndrome, about emotional load, about holding space for people who are profoundly sick. Um, and working with highly traumatized people that actually have a significant amount of psycho-emotional trauma, or people that have a significant amount of medical trauma because they are sick. And also the urgency that people feel about their health and the fear, working with people who are in a state of, really significant fear of their future or in pain, and how to hold that space as a practitioner without burning yourself out. Right. You cannot consistently regulate complex autoimmune cases if you, the practitioner, are dysregulated, if you are overextended, and if you are afraid to hold boundaries. Right. Boundaries are really necessary for keeping us and also the person that we're working with in a safe space. So the practitioner nervous system matters a lot when you're working with complex cases. Boundaries matter, and the pace that we work at matters both for the practitioner, but also for effective interventions for the people that we're working with. And the last part of that is that community matters for the health of the practitioner, right? We need to actually be working in a community of like-minded professionals who are understanding the complexities and the struggles that we have on a daily basis as part of working with in clinical practice with autoimmune disease and complex cases, right? So when you are held by your community and when you have a safe space that you can show up and workshop problems that you're having and talk about struggles that you have with your clinical practice, that means that we can actually show up as our best selves in clinic, right? So that was a really important thread that wove through the entire year was having the community and having a space that we can workshop these things helps us to hold space and be better, effective practitioners in our clinical practice ourselves. So, what are my predictions for 2026? Right. So, I see several very clear shifts coming down the pipeline that I'm kind of excited about. So first is immunology and systems thinking. So something that I wanted to talk about here is that we are 5 years into the prodromal phase of the post-COVID autoimmune wave. Right. Yehuda Schoenfeld, who is one of the world's leading autoimmunologists, has very clearly called SARS-CoV-2 the autoimmune virus. And we know that autoimmunity that is initiated from infection takes somewhere between 5 and 15 years on average to go from initiation of autoimmunity in a susceptible person through to diagnosable autoimmune disease. So we're 5 years into that now. Um, and even though testing is improving and identification is improving, these rates are going to rise. And I think that we are behind the brake of a wave. At the same time, the field is really moving away, necessarily so, from narrow immune protocols. We are moving away from Th1, Th2 protocols. We're moving away from single pathways. We're moving away from single gene polymorphisms and SNPs. And we're moving towards an integrated immune, metabolic, mitochondrial, immunological lasagna thinking. And that is necessary for us to be successful moving forward. I'm glad to see that is being borne out in the literature. It's being borne out in the conferences that I attend, and I'm seeing it again and again in the people in the industry, Jeffrey Bland and Aristo Vojdani, the giants whose shoulders I stand on, are thinking similarly, which I think is important and, of course, for me, very exciting. Then the next very important shift is a much more practical one, and it's around food and metabolism. So I'm seeing a quiet but really important shift around the way that we're thinking around food. And I think that there is currently, and I know that you will be seeing this as well, a lot of noise around protein, around fiber, around individual nutrients. There's a lot of important discussion around folinic acid, for example, or around methylfolate, individual nutrients, the iron on its own, vitamin D on its own, fiber, very important, but on its own. Or we're seeing like ergothioneine as an individual nutrient, or we're seeing specific superfood. This is the way the industry works, right? There's been so much discussion around curcumin, which is for many years, right? Which is an individual chemical among 200 from a single food, right? We have a tendency to narrow in really, really microscopically around protein is the current one. Fat has been there in the past. And what I'm seeing as a reflex from that is that there's this growing recognition that our bodies are not machines, that this is a 20th century way of thinking about food, and that food isn't fuel for a machine. Food is conversation. It is a conversation between the environment and our bodies, between the environment and our microbiome, between our microbiome and our immune system and our mitochondria. And that we can no longer think about our bodies in terms of machinery, a fuel for a machine, and to isolate individual nutrients or individual component parts of food, right? That we actually need to be thinking in complexity and to be thinking about the messaging that we are creating with food that allows our body to have complex conversations between the systems. Um, Similarly, that you cannot get fit by only exercising one arm. You can't create health by narrowing the diet or narrowing a supplement program to just one nutritional focus or one nutritional obsession. This isn't health, and it isn't how we create health, and it isn't how the body works. So that is one of my predictions for 2026, that we will be able to zoom out and think in more complex terms and think about food as interlocution rather than it being fuel for a machine. And a little shout out to Hannah Lendecker for helping me with the language and the thought process there. I want to talk about human relationships, artificial intelligence, and community, right? So AI is already and absolutely will continue to change how we analyze data in medicine and in healthcare. But the more that we integrate AI and the more that our patients are integrating AI, the more that the therapeutic encounter comes into focus as being not just valuable, but necessary. People, especially people who are struggling with their health, part of the reason that the medical system is failing so many people is because people need to be heard. They need to be held, energetically speaking, in a therapeutic sense. People need to actually have their whole story understood, and there needs to be clinical experience and nuance and the ability for clinical intuition as part of that. Right? So I actually think that what we need to see is a return to local community. And I think that actually, as we've broadened out um, with the internet, to be globally present and to be globally connected, as we start to integrate AI, I think that what we will need to see is the human community connection for healing. We will need to see a return to local community. And I think that we need to see practitioners working together, that we need to start really be connecting with our local health stores, our local library spaces, our local healthcare network, and our local doctors. And that we in the functional medicine and allied health space are actually perfectly placed to fill a space where the village GP used to be. Um, Not in a medical sense, but that there needs to be a connection to somebody who has the ability to see the whole family, to see the family as they evolve over years, to be an integrated part of the local community, and just to be able to hold the context of the whole picture of someone's life in a way that isn't possible at the moment, where the medical community, out of necessity, is really just dealing with symptoms and like a 10-minute appointment. So as the AI is able to hold a wider range of data, we are going to need a person, a human, to hold space and to create a healing environment that integrates that data. So that is actually something that I see as a massive benefit for AI. And it is how I see the evolution of our community and the role that we play in being kind of future focused. And I am also really excited about that. We do need to be integrated into communities. Humans need that to be healthy and to feel well as part of, that community aspect. So I'm excited that AI, which is so data driven and kind of futuristic, actually allows us to come back to a humanness that is old fashioned and very healing and very important. So when I look back on 2025, I don't really think of it as a year of more information. I think about it as a mature of maturation and integration, right? Understanding how to hold things in context. We have really workshopped through kind of tolerating uncertainty and having balance slowing down and creating space and doing less in order to be more effective, um, of having a process instead of pressuring for a specific outcome. So that is also how the Autoimmune Academy is evolving. That is how we are holding space with practitioners. It is having these discussions that aren't being had anywhere else and holding each other through evolution and growth. As we integrate what we've learned in order to be in the best service of our communities, as we are, working towards the health of the people that we serve, but also ourselves and the health of our own clinical practice. So, if that way of thinking resonates with you, and you would like to have a community and to deepen your clinical judgment and not just collect more protocols and more PowerPoints, um, so the doors are still open to the Autoimmune Academy to the end of this year, and then I will be doing another intake in March. I will pop the link to my website and my newsletter in the below this video, so that you can stay connected with me if that is something that you would like to do, and stay in touch with regards to the Autoimmune Academy or also any of my EBV content that I've got coming up over the next 3 months. So I would love to have you as part of my community, and for us to be in community with each other for 2026. I wish you all a wonderful 2026 and, of course, always the very best of health.